Good evening, everyone. I am Harsha, representing Science Integra, and I extend a warm welcome to all of you for 17th webinar of Maha Smiles Cleft Care for Every Child. This event is organized by AMOX in collaboration with Smile Train India. And the Public Awareness Committee, FOXY, with the aim of creating awareness about cleft lip and palate conditions in children. So it's my pleasure to introduce you all to Dr. Chavi, who is the Program Officer of Smile Train India. Over to you, ma'am.
Hello, good evening, everyone. I'm Dr. Charvi. I'm Program Officer with Smile Train India. Maha Smiles is a CSR collaboration between Bajaj Finserv and Smile Train India to build awareness and support treatment for children with clefts in Maharashtra. Maha Smile will enable nearly 8,000 life-transforming cleft surgeries to children in need in Maharashtra in a period of 36 months. The webinar series with AMOGS and Science Integra aims to facilitate resources among the AMOGS community about diagnosis and timelines of cleft care, and also build linkages between AMOGS members and Smile Train treatment centers so that children in need, expecting parents, can get prudent and timely help. So this is our toll-free number, 1-800-103-8301. Please refer children and parents in need to Smile Train India, and help us, give the cleft children live healthy and full lives. So now I'd like to introduce Dr. Monica. Please show me her CV.
Ma'am, it's absolutely okay. I am the convener of the series. I'm Dr. Monica Amberton. I'm the zonal coordinator for AMOGS. And my co-convener is Dr. Supriya Arwari, madam. She is also the chairperson of the Adolescent Health Committee of AMOGS and the Cultural Committee, the past one. This is the 16th episode in the series that we are doing with the Smile Train. And it is the constant support from your organization, ma'am, that we will be able to carry out these webinars and sensitize our doctors for a very important topic like this. Today, to highlight the issue of breastfeeding, we have chosen Dr. Mangala Vani, madam, as the speaker. And she will be speaking about the difficulties in feeding in these babies. So we have our AMOGS president, Dr. Kiran Kurti, sir, with whose constant support is our pillar of strength, that we can go ahead with these programs constantly every month. Over to you, Kiran sir, for your words of blessings and wisdom, sir.
Thank you. Thank you so much. Thank you for inviting me for this particular webinar, and not only for this webinar, but thank you for taking this initiative, Science Integra as well as Bajaj Finserv. Because on one hand, we have these two great organizations who, in case they partner with another good organization, that is AMOGS, I think a lot of people will be benefited. And I think the second slide that which you have shown, I think if it is feasible, Dr. Monica, please take a snapshot of that site, so that all the doctors all over Maharashtra know that where the free treatment for cleft lip and cleft palate can be provided. With this, my fellow guest of honors, Dr. Pardeshi, Dr. Varsha Baste, and today's special guest, Dr. Sneha Buyar, conveners Supriya and Monica, and of course, today's MOC is Dr. Pratibha. So, it's really a pleasure for me to be the chief guest for this 16th or 17th episode of the Smile Train, and indeed a great work that we are doing. And I will look forward to listening to Dr. Mangalavani as well as to Dr. Puneet Batra on what they have to speak on breastfeeding and cleft lip, and of course on orofacial cleft and from orthodontic perspective. So thank you so much. Thank you for inviting me, and I hope, wish and pray that this entire year the series continues and many of the children are benefited from that. Thank you so much.
Thank you so much, sir. It is an honor to have you with us today, and thank you for the constant support for this series and to all the activities that you we carry out under your AMOGS banner, under your leadership. Thank you for being there for us today. We move on with the next part of this program, that is Our next guest of honor, Dr. Varsha Baste, madam. Can we have our CV? Ma'am is currently the Vice President of Foxy. She has been the Director of Baste Maternity Hospital and Pushpa Fertility Center. She has the first ICSI PGT baby born in North Maharashtra. She has also been awarded the prestigious Anandibai Joshi Award and the Amox B for Screen Puraskar by the Governor of Maharashtra. We welcome you, ma'am, and it is an honor to have you with us.
Thank you, Monica, darling. I always call you darling because you are really a darling of amoxials. I have seen you working so much, so hard since ages, and you are the person who helps everybody in everything. And I'm really proud of you. Really looking forward to all your webinars. Wherever you call me, I'm always available for you. I'm really thankful for your invitation of this some Anokha smile train. What is the? I really like the concept, and also it is such a needed subject. Though it was not that regularly, we were looking forward to this work. But it is such an important thing, the cleft lift and the orthodontics and everything, how to feed the baby. It is such an important subject and topic to have more updates on this issue. I'm really thankful for you to make me guest of honor for this wonderful webinar along with Dr. Pardeshi sir, Dr. Sneha Bhuyar, and also the conveners, fantastic conveners like Monica and Supriya, who are the effervescent workers or karyakartas of AMOX. And I'm really, really thankful to see to see no, Dr. Kiran sir as a president and chief guest. And I'm really thankful for you to give me the platform along with such stalwarts. Dr. Pratibha Baldava, I'm really fond of her as she's here as a master of ceremony, and I couldn't meet her virtually. And the chairpersons, I know all of them, and the speaker, what should I say about Dr. Mangalavani? Such a lovely friend, such a knowledgeable, down to earth, kind, mild, and whatnot. She has got all the qualities a leader should have, and such a person, really pleasant personality. And she's looking beautiful day by day. Dr. Padra, I'm really happy you've been here to give us the updates about the orthodontics. So this webinar is some different kind of webinar, I think, and it is really a must for all and every gynecologist to attend it and to get newer updates. Thank you, Monica, for inviting me, and I wish all the best to Dr. Monica, darling, Monica Umbardan, and Dr. Sneha Bhuyan, and Dr. Supriya also for their further endeavors. Thank you. Over to you.
Thank you, ma'am.
Thank you so much.
Much.
Thank you,
Supriya, ma'am.
and
Yes,
thank you,
ma'am.
Monica, for being the really rock solid pillar behind Smile Train for so many weeks together. She's been shouldering the responsibility of carrying forward the Smile Train. Thank you so much on behalf of all of us who are taking advantage. Thank you so much. Next, it is my pleasure to call our special guest for today, Dr. Sneha Bhuyar, madam. Can we have Madam CV? Madam is somebody who needs no introduction to this August platform, but all the same, she's an international MS Signature awardee for Phenomenal Leadership 2020, Asia GCC awardee, Dr. S.N. Malhotra Individual National Award for Outstanding Work in Rural Obstetrics, Dr. Durusha Distinguished Community Service Award 2022, Individual Award Championship of Foxy, that is 2 consecutive years, 2020 and 21, and Dira Award 22,
Thank you, my dear.
Jeshi State Awardee, and Lokmat Healthcare Excellence Award. Umpteen number of talks, lectures, moderation of panels, publications, chapters, you name it, and it is there in her CV. And currently, she is serving as the chairperson of AMOX committee. Madam, welcome and thank you for coming to bless this session. And
Thank
over
you.
to you for your pearls of wisdom.
Thank you, dear. Thank you so much, Dr. Supriya and Monica at the outset. A very good evening to all of you. Let me thank and congratulate AMOX President Dr. Kiran Kurtakurti and of course my dear friends Monica and Supriya for having me here and of course having a wonderful webinar. The program itself, it has got a very noble initiative, I would say. Dr. Mangala Vani, of course, the chief guest, Dr. Kiran Kurtakoti, Dr. Pardesi, the guest of honor, and my dear friend, Dr. Varsha Baste, as guest of honor. It's really a pleasure sharing platform with you. Dr. Mangala Vani, a very close friend who is the authority in the subject, speaking on breastfeeding in babies having cleft lip and cleft palate, chaired by Dr. Pratibha Patil, President of Latur, Dr. Savita Padature, the President of Udkir Society, and Dr. Purnima Endi, the President of BEAD. Of course, Dr. Pratibha Baldava, our dear friend, as MOC, will do her job wonderfully. The second talk by Dr. Punit Batra, speaking on orofacial cleft and orthodontist perspective, chaired by Dr. Lalita Swami Madam, the President of Osmanabad Society, Dr. Anil Sakre, our dear friend from Nanded, President of the Society, and Dr. Rachna Jaju, Chairperson of the MTP Committee of AMOX. I would say we obstetricians are very closely concerned with the cleft lip and cleft palate because we have to tackle the feeding difficulties and the risk of aspiration in the initial few hours, I would say, initial few days. So it's really a wonderful initiative, and thank you once again for having me here. Dear friends, all of you know that I am an emergency obstetric committee chairperson for AMOX, and I have been working tirelessly since last 21 years for FOXY, holding 2 national posts till now. And about work, I need not tell you. Please do support, and of course, not only admiration and appreciation, but please convert your admiration into your valuable votes. And yes, I want to win with your support and your votes. Thank you so much once again. Thank you, everybody. Over to you, Dr. Monica.
Thank you, ma'am. Thank you so
And
much.
of course, very best wishes to both of you. Both of you are very deserving candidates. So all my best wishes to you.
Thank you so much, madam. Coming from you, it really means a lot. Thank you very much. And we will now proceed with the scientific session. So I would like to invite the MOC for today, Dr. Pratibha Baldava. Can we have her CV? Also, I would like to thank and welcome Udgir Society, Bead Society, Latur Society, Osmanabad Society, and Nanded Society. All their office bearers are there with us. And we are hoping to have a very exciting, academic section. We have Mangala Vani, none less than her, and I'm sure we'll have a great academic ahead. Dr. Pratibha, I think we can hand over the session to you. You can please start with inviting the chairpersons. Thank you so much.
Thank you so much, Supriya Madam, for having me here. I think we will straight off go off to start the sessions for now. Can I invite the chairpersons for today? Can I have their CVs, please? The chairperson for session 1 is Dr. Savita. Dr. Savita Padature. She is MBBS DGO, President of the Udgir Society, and she is running a private hospital maternity home since the last 2001. Since 2001, I welcome you, madam. Dr. Savita, madam is here.
Thank you, madam. Yes,
Okay. Next slide, please. The next chairperson for today is Dr. Purnima Yande, madam. She is the director of Sri Nirupula Hospital, Bead, and is practicing obstetrician gynecologist since the last 20 years with special interest in high risk of pregnancy. She is also a member of the district PCP entity and MTP committee. I welcome you, Dr. Purnima, madam.
Thank you. Thank you, madam.
Slide, please. Our third chairperson for today is none other than Dr. Pratibha Patil. She's a consultant at Siddheshwar Clinic, academic experience having undergraduate and postgraduate teacher for the past 30 years, and she has many publications to her credit. She has also presented many papers in AICOG at Bhubaneswar also. She is the president of LOGS in 2024 and 25. I welcome you, Dr. Pratibha Patil, madam.
Thank you, Pratibha, for your kind words. And I thank Monica and Dr. Supriya Arwari for inviting me for such a useful topic. Thank you.
Okay, now I would like to hand over the mics to the chairperson to invite our speaker, Dr. Mangala Vani, for today and take over session 1. Any of the chairpersons can introduce Dr. Mangala Vani, madam. Pratibha Patil, madam, please introduce Dr. Mangala Vani, madam, and then take over the session.
Yes. It's my pleasure to introduce Dr. Mangala Vani. She's an obstetrician and gynecologist and a lactation consultant. She's director of Hirkadi Gynecology and Breastfeeding Medicine Clinic, Pune. She's past president, Breastfeeding Promotion Network of India. She was a clinical secretary of POGS 2018-19, treasurer of MSR Maharashtra chapter, course director for lactation training programs, and Dr. Shirodkar Soreshan, Solapur OBGY Society. She is an Indian Achievers Award for Chikitsak Ratan by Global Society for Health and Education Growth, New Delhi. Young Scientist Award at 5th World Congress on Endometriosis, Dhanvantri Award, and Dr. N.B. Kumta Award. I welcome you, Dr. Mangala Vani, and we are looking forward to listen to your guidance to how to feed the babies of cleft palate and cleft lip.
Hello, Mangala. Mangala, you have to unmute yourself.
Yes, thank you, Sneha. So thank you, chairpersons, for kind introduction. And thank you, Amox, for introducing me. And I must congratulate Amox for having such a great initiative on this topic. And also, I see the other societies as well, the Udgir, Usmanabad, Nanded, and Beed. And I welcome you all. Thank you, Monica. You are always, a great initiator, and you have different ideas, and you are a very hardworking and very friendly person. So whenever I meet you, I know you are going to give me some commitment in the future. And that is what happened at the time of ICOG. Can I start sharing my screen? And thank you, the chief guest, Dr. Kiran Kirtakoti, the president, AMOGS, Dr. Varsha Baste, our chief guest, Dr. Sneha Buyar, a very close friend, and we have done a lot of breastfeeding activities together in her tenure as a chairperson for FOXY committee. And it's great to see you, Sneha. You see my slides now?
Yes, ma'am. Yes.
Yeah, make it full screen, Mangala.
Yeah.
Yeah.
Okay. Great. So let us now go to the subject. There is some problem with my laptop, and I'm unable to see my full screen, so I may miss few words, on the right side. So this is an important topic that we are going to talk today: the breastfeeding in the cleft lip and the cleft palate babies. And we gynecologists are not much aware of this subject. Now, when I'm talking to on this subject, first I must declare that I have no conflict of interest on any devices shown in this presentation, and they are only for knowledge and learning purpose. And special thanks to Nair Hospital for giving permission to share the photos, and Dipti Shah for sharing few of her slides for the education purpose. So the cleft lip and palate, it is about 0.8 to 2.7. It is a worldwide per 1,000. And Asia, it is 1.7 per 1,000. So we are a little bit on the lower side. And they're more common in, somehow I'm not seeing the full, this thing. Let me open my PPT on my mobile also. Just give me a second. Yeah, so it is more common in Asian and American, and the cleft lip and palate, they are more in male, and the cleft lip is more in male, and the palate is more in female. And it is mostly unilateral and more on the left side, the cleft lip. The cleft of the lip is normally, the development is, during 5th to 8th week when there is a fusion occurs, and the cleft palate from 6th to 12th week onwards. So if you see the risk factor, why it happens, so actually it is a multiple factors. So it could be genetics, environmental, smoking even has has some risk factor, alcohol, folic acid deficiency, excessive retinoic acid, and suppose exposed to teratogens or exposure to even the German measles. Other infections can cause, particularly in the early pregnancy. And some medications like anticonvulsant or psychoactive drugs, may increase the risk of baby having cleft lip or cleft palate. Now, if you see, the bonding issues, sometimes it may not be diagnosed during pregnancy. And previous days, actually, it was a stigma in earlier times. And when the baby is born and you see the baby's face, for mother particularly, it could be very shocking, even for the family. And it is they get distressed sometimes, and it can be very painful experience. But actually the mother say while the baby is breastfeeding, the baby looks normal. So that is a good feeling for the mother. Now there can be a lot of problems when the baby has a cleft lip or cleft palate. So what can happen? Trouble in maintaining a good seal and vacuum. So what happens, when there is a cleft lip or cleft palate particularly, now the nasal cavity and oral cavity, there is no partition in between with the palate. So, baby cannot create adequate suction for, getting the milk from the mother's breast. So she cannot get the good seal, and the suction. And so babies, they tire more easily. And even they will breastfeed longer without any satisfaction, and they may not get the enough milk because of the less negative pressure. And they prefer the side which is without cleft, because mostly, as I said, it is unilateral. So probably they will use more on the other side. There can be gagging and choking and reduced milk supply. Obviously, why reduce milk supply? Because to maintain the milk supply, it is, a demand and supply. So demand means what? There has to be more stimulation of the breast. There has to be more milk removal from the breast. And that is frequently, means every 2 to 3 hourly, minimal 8 times in 24 hours. So if that happens, then only mother's milk supply is maintained. Now, if the baby is not able to suck properly, if my baby is not able to produce the vacuum, so definitely the breasts are not stimulated as they should have been. So the mother's milk supply also eventually goes down. So there is a weak suck of the baby. Then there is a nasal regurgitation because, they are connected. So the milk actually comes through the nose. And this could be even distressing to see, for the mother. And if the baby is not monitored properly for the nutrition, for the adequacy of the milk that baby is getting, this baby will have impaired growth and impaired nutrition. So there are a lot of things that could happen. So if we just see the background for the cleft lip, the cleft lip is formed in the top of the lip as either a small gap or an indentation in the lip. So it could be partial or incomplete, or it could be complete cleft that it continues into the nose. And it is due to the failure of the fusion of the maxillary prominence and medial nasal process. That is a formation of the primary palate. And unilateral clefts of the lip are twice as likely to be on the left hand side as compared to the right side. So you can see in the figure, the cleft, it can be unilateral and incomplete, means they are not going into the nose. So they are just below the nose, the upper end is. So unilateral complete means it is going into the nose, and the bilateral complete means it is on the both sides. Now coming to the management, in the case of cleft lip, we still have to discuss further factors, but I'll go step by step. Now cleft lip is oriented towards the top of the breast. So when we are holding the baby, so this is our newborn baby. Say hello to everybody. And this is so suppose the baby has now the cleft lip on the left hand side. So when mother puts the baby to the breast, this cleft has to come on the upper side, not on the lower side. So if she puts the baby to the left breast in the cross cradle position, so that left side comes up, the left cleft lip comes upwards, and then what happens, she pushes the maximum breast towards the cleft. So what happens, that gap is closed with the breast tissue, and then there is a possibility of baby will able to suck and able to produce the negative pressure in baby's mouth, and she will able to take the breastfeed. So this is very important. Now she's on the left hand side, it is a cross cradle, but on the right side, if we take the baby again like this, the cleft is going to go down. So this is not good. So again, to keep the cleft upwards, so what she has to do, in the same position, she has to bring the baby to the right side. So this is like football position. Or you can see like the twins, they hold both babies together. So she can hold the baby in the football position. So all this may be complicated little bit, but I think once we have little understand the basic, which if time permits, we can discuss. So these are very important when there is a cleft lip. With the cleft lip, there is a good chance, particularly if it is incomplete, that the baby will able to breastfeed. Now I just want to ask the question to the delegates, that are you or your health professionals, whoever are helping the mother and baby diet for breastfeeding, are they competent enough to help this mother and baby for the proper latch? And it will be interesting to know, what the answer is. There other positions mother can try. So occlude the cleft lip with the thumb or with the finger, so that when it is, this is like gap. So if you just occlude, then the suction is created. Or the teacup hold. So she can just hold the nipple where the cleft lip is, so that this tissue goes into the lip gap, and then the suction is created. Or for bilateral, suppose both sides there is a cleft lip, then she can take the straddle position. Straddle position means what? So the baby actually sits on the mother's lap or something else, and so baby is vertical. So it is likely that, it will not regurgitate from the nasal openings, as well as the baby will able to produce some suction. That is very important. So we come to the normal babies, how the latch should be, before we go for a complicated or problem babies, because cleft lip and cleft palate is a bit complicated. So unless and until you learn in the normal babies, you won't able to help these babies. So when there is a good latch, that means what? The baby's mouth is widely open and the lower lip is turned outside, everted outside. Baby's chin touching the breast, and the maximum portion of the areola, or what we call as the black part in the mother's language. We don't say all black part. It is not possible, because this areola has a different sizes. So sometimes for the baby's mouth, all areola will not go. So as much as possible, the areola and the nipple inside baby's mouth, and so the tongue is under the teeth. So these are the important points. So this is in Marathi because our organization BPNI Maharashtra, Breastfeeding Promotion Network of India, we do give a lot of training in the urban, rural, to the hospital, to all health professionals, whoever wants. So there we show this kind of slides. Now coming to the formula, because we always think, yeah, there is an alternative formula. What's wrong with it? Without knowing, recently we visited one hospital for BFHI. BFHI is Baby Friendly Hospital Initiative. And none of the staff, when I asked them what is formula, they just started looking at each other. They didn't know actually what the formula is. And if we don't know what the formula is and we are giving that to baby, I mean, you can imagine the consequences. So it is basically the cow's milk and modified with other ingredients. And it has a fixed static combinations, no correlation to increase intelligence. Remember, the breast milk has good components, good fatty acids for the baby's brain development. It does not have immune boosting qualities. And of course, it is so expensive. Formula companies are there to earn money. They are not there, for our baby's health. And there are no live cells, no antibodies, no growth factors, enzymes, hormones. There are so many things in the breast milk, none of them. So we call even the breast milk sometimes as a white blood. So it takes twice longer to digest than breast milk. It has more casein in it. So feeding frequency is less and it can cause the more gas and the diarrhea to the baby. There are more additives are added because the formula dibba can sit in the cupboard for 1 year without any germs in it or anything, because so many additives are added into that. There are many practical challenges with the artificial milk, the producing, the buying, the money, then the clean bottles, the clean water, the exact proportion of the water, and the temperature of the water. The causes formed brown stools that have a noticeable odor. The breast milk causes loose yellow stools that has a sweet odor. Now, what are the normal recommendations for breastfeeding? That first is give mother to hold the baby in close contact, skin to skin, and initiation within 1 hour. Exclusive breastfeeding for 6 months. After 6 months, we start the complementary feeding, but we continue the breastfeeding for at least till the baby is 2 years, second birthday. And we need to converse and communicate while feeding. That is interactive feeding. Important these 4 recommendations. The expression of the breast milk. Suppose the baby mother is not able to latch the baby is not able to suckle the milk at the breast, then what mother has to express the milk, and that we have to teach the mother how to express. She doesn't know these skills. So the expression, knowing the skill how to express the milk in those babies, of course every mother has to have this skill, but specifically the babies who are unable to latch, this skill is very important. And manually expression, or now there are very lots of good hospital graded electric pumps. So though for those kind of pumps are very helpful in the beginning, so mother can use these pumps as well. So we just now come to the cleft palate. So it is a congenital deformity in which the palatal shelves at the roof of the mouth fails to close during the early month of prenatal life. The cleft palate can exist in varying degree of severity, ranging from the fissure of only the soft palate to a complete separation of the entire palate, including the gum. So, the severity varies. And again, there are 3 types: incomplete cleft palate, unilateral complete lip and palate. So they are all together, starts with the cleft lip and it is all the way the cleft palate. And it is can be bilateral or unilateral. Or there can be just submucosal, means the bones are separated, but there is a little mucosal thin lining is still there. So we may miss the cleft palate in that case. So what are the problems that we can come across with such babies? So difficulty feeding. Now, particularly with cleft palate, it is difficult because, as I said earlier, the nasal cavity is connected, and the baby, most of the cleft palate babies, they find breastfeeding difficult, and it is very important that how we maintain the mother's milk supply and that baby gets that milk. Ear infections quite common in these babies, and hearing loss even can happen if the proper attention is not given. Dental problems can happen, even the tooth development can be affected. Speech difficulties and challenges of coping with the medical condition, social, emotional, and behavior problems, differences in appearance and stress. But nowadays, because the surgeries happen early and surgeries are so good and the scar is hardly visible, these problems are not much there. So how we feed the baby when the baby has a cleft palate? So it has to be baby upright position, and if you see the straddle position that I showed you earlier, that is very important, that baby is vertical and the baby supported at the neck. We never press the baby's head. We support the baby at the neck. And that is how the baby possible. So another thing is, if the mother's nipples more protrude and the flow is normal, then breastfeeding success is more successful. For example, if this is second baby and the mother has already breastfed the first baby, in that case her nipples are already protruding and they're formed and she's experienced mom. So to certain extent it may be possible. But when it is not possible for the baby to suckle, there is a lot of nasal regurgitation happening, babies getting tired, prolonged feeding, baby's weight gain is a problem. So in that case, then what we have to do? We have to, mother has to express the milk either manually or with the breast pump, and then we feed the baby. There are actually they can try with just the spoon or katori or cup feeding, but there are now specially designed bottles. First is the Haberman's feeder, and there is a special need feeder as well. There are different companies, so these are the pictures that you can see, and there are some more. Now companies have come forward and they are specifically making bottles for this cleft palate and cleft lip babies. So what is the difference between the normal bottle and the special need feeder? So it has a one-way valve. So when the baby stops it between the two sucks, the milk doesn't go back to the bottle, and the air squeeze out before the feed. And there is a slit valve. It shuts between the jaw compression, preventing the baby from overwhelmed. And we can squeeze the bottle. So there is a control flow to the baby. And the baby needs assistance, may apply the gentle pumping action to the body of the nipple. So these special prepared bottles should be used, for those cleft palate babies. So if you see the general plan of the treatment for this cleft lip and cleft palate babies, we don't have to go very much detail, but the after birth first consultation with the parents, feeding advice, and I would say not only advice, the practical support and the regular follow-up is extremely important. The counseling is extremely important in such cases. Generally, the orthodontists, they repair the cleft lip 4 to 6 months with nose corrections, and cleft palate repair happens between 8 to 12 months. And then, the regular, the ear checkup, the speech, the dental follow-up, all this eventually they happen. So we don't have to go into detail of that. So it is all the multi-speciality team when the baby has a cleft palate or the cleft lip, So feeding problems and child development, there we need lactation consultant, pediatrician. And I have taken this slide from Dipti, and I wonder why she has not written obstetrician here, because we are all sitting obstetrician and we have a very, very important role. unless and until we take the initiative. If we don't have the training, we should get somebody who is trained, and there are lactation consultants plenty now, so we can get their help and make sure the baby is getting the breast milk. Or then there is a surgeon, plastic surgeon, speech therapist, as I said earlier. Now, there are some certain recommendations by ABM. ABM is Association of Breastfeeding Medicine. This is the organization based in US, and they have many recommendations on different problems. So on the cleft lip and palate, there is a very important paper that they have published. So they say encourage parents to breastfeed and provide breast milk when possible. And benefits, we should tell the mother the benefits of the breastfeeding, the benefits of the breast milk. I think once the parents, they understand the benefits, then they will do anything, but make sure they get proper help. If we don't prepare them for the breastfeeding, if they don't understand the importance, and if we just label them, they are the IT people, or now the new generation is lazy and they don't want to breastfeed, that is actually not right. I'm an obstetrician, I deliver many babies, and I deal with educated mothers, and I think once we go through proper channel of the training, they all breastfeed and they are so happy, and we as a caretaker, we also feel very happy, when the mother breastfeeding successfully the baby. So we should tell her the use of different devices which support breastfeeding, and consistent and expert counseling should be provided by health professionals with clinical expertise in feeding infants with cleft lip and the palate. So timely assessment and support. Now this timely assessment starts during pregnancy if the cleft lip and cleft palate is diagnosed during pregnancy, and immediately after delivery, because as in my first slide I said, it could be shocking to see the baby and then the breastfeeding is not, if not possible, even possible, we have to help the mother for the proper latch, then only it is possible. We have to tell all those different techniques, and if it is not possible, within like 1 hour, what is recommendation, the expression of the milk has to be started, and on frequently, regularly, ongoing support, then referral to the specialist on timely, and join peer support group and local support group like the Wide Smiles, and look for other syndrome, because this could be not isolated, it could be part of some other syndrome. And implement the strategies to support the breastfeeding, find out the suitable feeding position, teach manual expression. That is also a skill, that there is also a certain way, not just some massage wali bai or aya bai comes and they do in a very wrong way actually, and we then get lot of cases with mastitis and even abscess because they traumatize the breast tissue so much. The use of breast pump, again, I won't recommend the manual breast pumps, even they are cheap, just in couple of ₹100 they can buy, but they can damage the breast tissue. So it has to be proper breast pumps, use of special bottles, and monitor of hydration and weight gain. This is extremely important, the monitoring of the weight gain of the baby. The prosthesis used for the orthodontic, one second. Yeah, the prosthesis used for orthopedic alignment prior to surgery, and strong evidence suggests that they do not significantly increase the feeding efficiency. They are just for the alignment, and they don't close the airtight the cavity. So they cannot, create the negative pressure even if the baby is wearing the prosthesis. So wearing prosthesis doesn't mean the chances of breastfeeding will increase. And breastfeeding can commence immediately following cleft lip repair and 1 day after cleft palate repair without complications to the wound. So that is also important information. So it is important when we are educating the mom. How does the breastfeeding help in those babies? So, of course, it is more nutritious, easier to digest, immune protection, and it is particularly, the acute otitis media, which is quite common in these babies. The baby will be protected from that because the milk has lot of immune properties. It helps minimize allergy, the digestive system, it makes more mature. Post-operative nutrition, because after baby undergoes surgery, baby may refuse the bottle or other nutrition. The baby normally doesn't refuse the breastfeeding. It promotes the eye and the brain development and economical. So there was just a little cartoon.
Hello. I think, madam, there is some network issue, is it?
Yeah, madam's slides are not being seen, and madam is also not being seen.
Mangala
I
ma'am.
I think I'm there now.
Yeah.
Bangla ma'am?
Yeah, I'll start sharing the slides again.
Yes,
Yes,
ma'am.
ma'am.
Yeah, just give me a second. Yes, you can see now. Can you see now?
Yes.
Yeah.
Yes, ma'am.
Yes,
Yes.
ma'am, they are visible now. Yeah, you can do full screen.
Okay.
Yeah, they are visible now.
Great. Yeah.
Full screen. Yeah. Yes, ma'am.
So that is what happens. So as I was saying earlier, the antenatal class is very, very important, giving all the information to the mothers. So the role of lactation, again, very important in such cases. So they can teach mother the importance and help practically for skin to skin contact, early evaluation of the breastfeeding. They can try different positions and the milk transfer, whether it is adequate or not. And if it is insufficient or baby is unable to latch, they help with the colostrum expression and optimal expression techniques they know, and implementing strategies for maximizing milk transfer and supply, such as pumping sessions, breast massage, and use of galactogogues. Galactogogues are the medications which increase the milk supply. Again, how they can supplement, how much milk needs to be supplemented if the mother's milk is not enough, the how baby can be fed, the methods, and encourage them to join the support groups, counsel about breastfeeding success, psychological support, and give the feeding plan. So lactation consultant can do so many things. And of course, if the obstetrician is also trained in the breastfeeding medicine, then there is nothing like it. So when the mother asks, can my baby breastfeed directly? So what could be the answer? The chances are more with cleft lip than cleft lip and palate. Palate, the chances are not that much, the direct breastfeeding. But yes, the giving breast milk completely, exclusively is possible. And if complete cleft lip or palate difficult to seal, so use express milk, and it can be given by cup, water spoon, bonla, or the special bottles. So when these mothers, they make milk enough for the baby, they are so happy, they are so satisfied. So this mother is asking, and she's telling that I make milk, so what is your superpower? So she feels empowered. This is a famous psychiatrist from USA, and he says it's lucky baby I feel who continues to nurse until he's 2. The breastfeed, you know. Another two things I just want to mention.
डिलिव्हर व्हायला हवी ना
I finish. One is,
दोन्हीतली कुठलं तरी एक फायनल कर म्हणजे बाहेर घरून जे येणार आहेत त्यांना सांगता येईल ना
I think everybody has to unmute. There are a lot of noises in the background. I mean, mute. Everybody needs to be muted. So BPNI Maharashtra has two projects right now. One is IBCLC. IBCLC is International Board Certified Lactation Consultant. So this is the international master's degree, and we conduct the courses to complete the requirement for that. So if anybody is interested, definitely they can contact me. And another is BFHI, that is Baby Friendly Hospital Initiative. That to get the breastfeeding successful in the hospital, if they adopt these 10 steps which are recommended by UNICEF and WHO. So we certify them as a baby friendly hospital. I mean, we give the training first to all the staff, then we assess, and that assessment is very rigid. And then if we are satisfactory, then we assess again after a few months, give them some chance to see whether they improve the practices, and then finally we certify them. So anybody wants their maternity hospital to be baby friendly, we'll certainly do that. So these are the resources for my presentation, and thank you so much.
Thank you, Mangala Madam, for that lucid talk. It was indeed very informative, and you cleared most of our doubts. And you have also mentioned how we could very easily and comfortably feed these cleft palate and cleft lip babies. Thank you so much, Madam. And we are really thankful to you from the bottom of our heart.
Thank you so much.
Now we move on to session 2. Can I invite?
There are any questions we can take now?
Yes. Yes, madam. If there are any questions and answers, if there are any questions for you, I'll definitely let you know, ma'am.
Thank you.
Yeah. Thank you so much, madam. Yeah. Now we move on to session 2 for today. Can I invite the chairpersons for session 2? Harsha, please put forth the series of session 2. Yeah. The chairpersons for session 2 is Dr. Swati Lalita. Dr. Swami Lalita, madam. She is director of Swami Hospital, Usmanabad. And she's a consultant at Swami Hospital, Usmanabad, worked as a medical officer at PHC, and she has multiple tribectomy camps, worked as a medical officer at Civil Hospital for the last 15 years, and president of Usmanabad, president of WDW Wing, IMA of Usmanabad. I welcome you, Lalita, madam.
Yes, thank you, ma'am. Thank you.
Yes. Next slide, please. Our next chairperson for today is none other than Dr. Anil Sakre, sir. He's an ex-associate professor, Department of OBGY at Nanded. He's worked as an assistant professor at GMC Nanded for the past 11 years, and he's an undergraduate and postgraduate teacher and examiner. He's an operating faculty of live surgical workshops at many of the conferences that we see, and he has 23 scientific publications to his credit, amongst very few Indians who have contributed in the Williams textbook of obstetrics. Also contributed International Reference Book of Operative Obstetrics by Cunningham. He is an experience of operating more than 7,000 NDVH cases. He is an organizing secretary for MOX 2012 and 17. Received many awards for his social service and contributions. I welcome you, Anil Sakre, sir. Anil Sakre, sir, are you there, sir? Dr. Anil Sakre, sir, is he there? Okay, we can have the next slide for the next chairperson. Our next chairperson for today is my very dear friend from Latur, Dr. Rachna Jaju. She is a member, Aesthetic and Sexual Medicine Committee, amongst 22-24, Secretary of MPH 22-24. She is a chairperson of the MTP Committee of AMOGS at present. She has been the treasurer, IAG, Latur, a faculty at many of the conferences, and she has been an organizing part of the organizing team for Mahabaleshwar, Pune, Latur, Nasik, all these conferences, and she's conducted numerous adolescent health education workshops. I welcome you, Dr. Rachna. Are you
Thank you
there?
so much, Pratibha. Yeah, I'm there.
Yes,
And
yes.
thank you so much for that kind introduction.
Yes. Now I would like to hand over the mic to the chairpersons. They can introduce the second speaker and then go ahead with the session too. Rachna, you can introduce the speaker, the second speaker.
It would be my honor and privilege to be a part of this program of the Train Smile. And an orthodontist from here, Dr. Yatish Joshi, had called me yesterday and he told me that Dr. Puneet Batra sir is our mentor. So such is the aura of this person. I don't think there is any need for introduction of sir. But yeah, sir is Vice Chancellor at Manav Rachna International Institute of Research and Studies, Delhi NCR. He's Dean, School of Dental Sciences and School of Allied Health Sciences, Professor and Head of Department of Orthodontics and Dentofacial Orthopedics, President of the Indian Orthodontic Society. He is the Editor Journal of Indian Orthodontic Society, and he has been awarded with PP Jacob Award for Best Scientific Paper. Then Best Paper for Professor J.G. Kanapan Award for Best Paper, Indian Society of Dental Research. He has professional experience in cleft orthodontist, and he is past president of the Indian Society of Cleft Lip and Palate and Craniofacial Anomalies. He has been nominated to the Dental Council of India by the Government of India, and he has memberships such as Smile Train Indian Advisory Council. And we look forward to your great session, sir. We welcome you.
Thank you so much, ma'am, for this kind introduction. I'll be just sharing my screen. Is my screen visible? Is my screen visible, ma'am?
Yes, sir. Yes, sir.
Yes. Yes.
So, thank you very much, and I want to thank Smile Train, which has changed the course of my life. It has changed course of so many lives because of the work they do for cleft lip and palate children. But again, the AMOX, the Foxy, I think it's a great initiative to educate our fraternity as well as people about what can be done in getting good outcomes for cleft lip and palate children. So I'll be talking about the orthodontic perspective, and orthodontic perspective changes smile. So this Maha Smiles is actually something where my journey started off from this patient. I saw this patient in Global Hospital in Mount Abu about 21 years ago, and I didn't know what was the plan I would do for such a child. But Smile Train has taken the perspective to a different plane altogether by making protocols and by showing the way how we can improve management of cleft lip and palate children. So there are protocols of management, and among them, the most important is how to attain a balance. The green shows in this pentagon what is a balance which is required to give best outcomes to the patient in terms of craniofacial growth, in terms of getting good occlusion of teeth, psychosocial appearance, as well as speech. So, cleft requires an interdisciplinary approach. Multiple specialties are required. Among them, the longest standing relationship which is there with cleft patients is an orthodontist. So, the lip repair is done, but before that, the parents meet an orthodontist. I'll be just showing you how we interact with the newborn. And, there have been projects done in Europe, in Scandinavia, in America, which talk about the role of primary surgery. The first surgery is the most critical aspect of getting a good outcome for this cleft child. And palate repair before 2 years is going to have an impact on speech and somatognathic system. So how does an orthodontist fit into this? So it's a journey, and I'll divide it into 4 parts. The first part is at birth. The second part is in the mixed dentition. This red box, which is an age of 7 to 8 years and 9 years. And when regular orthodontics is done at 12 years, when the patient has a permanent set of dentition, and orthognathic surgery after the growth has ceased. So, let's look at the child who's just born from infancy to the mixed dentition. Feeding plates used to be the course for helping in feeding the children with cleft. However, there is evidence that feeding plates don't actually work. So, in very rare cases, it might have an impact, but usually feeding plates have no role in feeding for cleft babies. Pre-surgical infant orthopedics is something we do. Now, what is the principle of this pre-surgical infant orthopedics? When the mother has delivered this child, the maternal estrogen levels are very high during the first days of life. So what does this do? It leads to an intercellular material becoming disconnected. So, just like plasticine, you can shape the nose and the lip so as to make surgery very easy for the surgeon to give a good relationship. So it was Dr. Barry Grayson in New York who designed an appliance like this, which, and made this procedure called nasoalveolar molding famous. The word naso is nose, alveolus is where the teeth erupt, and molding is the process of utilizing this maternal estrogen. And this estrogen falls rapidly after birth. At 4 months, it becomes almost zero. So we have to see this child from birth till 4 to 5 months and then refer to the surgeon after we have done a good molding. So have a look at this bilateral cleft. The premaxilla is jutting out. Now, for a surgeon to do a lip repair without tension is not easy. So what have we done? This is the premaxilla which is jutting out. We've given a plate and we've done molding and brought this back. So it becomes easier for the surgeon to be able to do a good lip repair. Now have a look at this child and have a look at this premaxilla. How difficult it would be for a surgeon to do a good lip repair. Also, we have some columella tissue here. There is no columella tissue in this child. Now, if this was to be operated, we wouldn't get an optimal outcome. But nature, because of this maternal estrogen, we can mold it. We can give it shape. So have a look at what we've done. So if you go back, this was what we had, and this is what we've given for the surgeon to operate. So, this is a great changer which can make life simple for the primary surgery. Similarly, have a look at this unilateral child. If you look at the intraoral photograph on the left side, you see that one side of the arch is collapsed. But if you look at the post outcome, it has become a very good synchronized arch. So, to get a good outcome, this is pre, you look at the nose, it has become symmetrical. So, it is easy for the surgeon to operate right away. Now, sometimes making a plate is difficult. So there are simple options like just an elevator, just a elevator tape, which will make this defect small and make it easy for the surgeon and give the columella, the convex, tissue uprighting to happen. So we recently started using something called as aligners. At COVID, what happened is that it was very difficult for a cleft baby and the parents to come to us every week. So what we did was that we, did give them aligners, 16 set of aligners. And what happened is that we got a final outcome. So once we got a final outcome, the lip, you can look at the patient's photograph on the left and the right side, you can see what the outcome entailed. So making it easy for the surgeon to operate this case. So now this child has grown up. The child is, in the mixed dentition. And this child is basically, come to us for bone graft preparation. See, what has happened is in a unilateral cleft child, the alveolar segments are two. There is a major segment and a minor segment. In a bilateral, there are two lesser segments and there is one protruded premaxilla. So preparing the patient for a bone graft makes that alveolar region into one single unit. But the catch is that it should be done at the time when the root of the tooth, which has to erupt through the graft, is 2/3 formed. So have a look at what I'm saying. Look at the collapsed arch in this patient. We've given the patient expanders and we've developed the arch into a normal arch form. Once we've developed this into a normal arch form, we should understand that why are we doing a bone graft? We need to put teeth there. We need to put implants there. We need to have a good nasal base. Have a look at this. This is pre-treatment before the bone graft. And now look at after the bone graft. So if you appreciate, the facial nasal symmetry is going to happen only after the bone graft. So have a look at this child. This child has unilateral cleft lip and palate. The bone graft has been done and the tooth is grafted. So if you look at the picture on the extreme right, you will see that it looks like a complete maxilla and having all the teeth in the mouth. So another patient, one of our publications from the iliac crest, bone has been taken and grafted, and you see what you get. You get a great set of dentition and outcome. So bone graft preparation is something which is important. Have a look at this bilateral cleft. So this girl has a scarred upper lip. Look at the outcome. She's an engineer and she is one of the influencers. You know, she was on the lipstick campaign of Smile Train and is a superstar because she's got that confidence and that smile that she's able to carry herself through. Another treatment we can do in the mixed dentition is protraction. What happens is that, you know, because of the scar of the lip, the maxilla does not grow so well. So you can push the maxilla outward by applying extraoral force, because maxilla unites with these sutures of the cranial base by 8 years. So if you give a protraction, this appliance is called a face mask. So we are taking the support of the chin and the head and pushing the upper jaw outside. So, you know, it doesn't have to be worn in school. It has to be worn 14 hours a day. So, you know, which is the time when you sleep and when you are at home. So it brings about changes. Have a look at this child where we've given this appliance and the patient is having a positive overjet. So, you know, we've encouraged growth in this child. Now, a patient has grown further. Now, all children who have 12 plus undergo braces to align teeth. Cleft children are a bigger challenge. Have a look at this child who's got a very sullen face. And I always say, look at the eyes of these children. You know, look at the eyes of this kid and look at the post eyes. You know, the eyes tell you the story. This is pre, this is post, this is pre. Look at the set of dentition, and this is post treatment. So, you know, by doing orthodontics in a planned way, we can get a very good set of dentition in cleft children. Another girl, you know, she was not going to college, but when we treated her, look at the eyes again. The eyes tell the story, and look at the post story. Pre and post. Pre, look at the outcome and look at the post. So orthodontics in these patients is going to change the way they are, you know, confident and socially amenable. Now, many of the cleft children have missing teeth. So we try to sometimes close spaces of the missing teeth. This child is, you know, she is doing very well in America. She was one of the younger patients who did, you know, got selected, and she is on a scholarship in a big university in America. This is the pre and post, and this view will be able to show you that there were missing teeth, but what have we done? We have just rearranged the teeth in such a way and done a bone graft at the right time to get a complete maxilla. So can anybody say that there is cleft? It doesn't seem to be. Now, sometimes you have to maintain spaces and give a bridge. So, you know, this child, look at the eyes again. They tell a story. Look at the eyes again. So, pre and post, pre and post. So, there is a bridge in place. Now, many times you can auto-transplant teeth. Lower jaw tooth can be transplanted onto the upper jaw to get good outcome. Now, implants are a big thing in dentistry, but do you know that the first implant in the world was placed in a cleft child? This was in Sweden. Professor Jan Lilja, did this case, and the first implant in human beings was done in this cleft child who died with the implant in his mouth for 46 years. So implantology is also not new, and implantology is also related to cleft treatment. So have a look at this girl. I did a few years back. She's got a missing lateral incisor. What I've done is I've aligned the teeth, and in the missing tooth, I've put an implant and a crown on top. So this is this girl smiling away to glory. This is pre and post. And this is the permanent dentition. But the battle doesn't end there. The battle continues because about 30% of these children have maxillary growth deficiency. The maxilla and mandible do not match each other in growth. So we have to prepare them for orthognathic surgery. Now, this boy, he is, an IITian and a superlative. He's opened an organization called, Cleft Warriors, and a great guy who I treated a few years back. So we did an osteotomy and we brought the teeth in a place there should be. So, osteotomy is one way of bringing the upper jaw out. But when the defect is very large, doing an osteotomy is not such a good idea. Now, the parent of this boy said they don't want anything because, he was born with great difficulty. So the mother said, he is my only son. I don't want any treatment, but do as much as you can align teeth. So when I aligned teeth, she said, okay, can we do some minor surgery? So we did a procedure called genioplasty. Look at the long face and look at what we did. We just shaved the chin a little bit surgically. And this is pre and post. So, orthodontics can change lives. When the defect size is very large, when, the maxilla mandible differential is more than 10 millimeter, we can do something called as distraction osteogenesis. So distraction osteogenesis it was done in this child to bring the maxilla forward and then braces to align the teeth. Sometimes you have to do a number of procedures together. So again, look at the eyes of this girl and look at the happy eyes here. So this is pre and this is post. So she has got her complement of dentition. The defect has closed and the bone graft has been done simultaneously. Sometimes you can distract teeth. You can move one side teeth to the other. So this girl, father was a carpenter. He said, Doc, I don't want artificial teeth. So we designed something called as an indigenously designed distractor, and we moved one segment of teeth to the other side. So you can have a look at the size of the defect, but after distraction, we managed to create bone, and we were able to have no artificial tooth in this mouth. So, came in this girl with the bilateral defect, and she said, what you did to that unilateral, we want to do with my daughter as well. So we did a correction. And I'll just show you how this got published in the Cleft Palate Craniofacial Journal. The cost of the distractor was only 5,000 rupees. Though, distractors are very expensive. So we got a complete maxilla without doing any extra procedure. Sometimes you can distract the anterior maxilla as well. And this is a good procedure because you don't lose the voice of the patient. The velopharyngeal incompetence doesn't happen. So pre and post, I've shown you, and I like to show this boy. He came to me when he was 11 years and we did treatment in 11 months. So, this boy look at the eyes again, look at the outcome of the lip repair and his final outcome after orthodontic treatment. So, we got this boy into proper shape. You can see stepwise what we did. We did, align the upper jaw after the lip had been repaired. We did distraction. And after that, we got full complement of teeth. And this all happened within a span of 11 months. So proper training is important. While these are the 4 stages of orthodontics, one at birth, because of the maternal estrogen, we can do pre-surgical infant orthopedics. Second, in the mixed dentition to prepare the patient for the bone graft. Third, regular orthodontics. And in about 30% of the patients, orthognathic surgery. But as a dental surgeon and a specialist orthodontist, it's very important to stop caries. So we recently published our work called STOP. STOP is Smile Train Oral Prevention Program, which was recently launched. And this is, a game changer for cleft children. It has 3 components. 1, anticipatory guidance, preventive and minimum invasion, and definitive restorative treatment. So, this is something which is very important. We should know how to prevent caries. We should know how to clean the gum pads, brush with fluoridated toothpaste, avoid sweetened beverages in the bottles, avoid, pacifier sucking, nail biting habit, check for white and brown spot lesions. Also, when the child is growing up, we need to use pea-sized fluoridated toothpaste, clean the oral cavity after every meal, and finally, final nighttime feed should, be water in the end. Now, we also need to make sure that the patient brushes at night because that is the time bacteria are acting on all the food he has eaten during the day. All the appliances need to be cleaned well. So, prevention and minimum invasive treatment is very, very critical. And then final restorations, because these patients have missing teeth or teeth which are in different shapes. So we will need some restorative care to give good outcomes. So, we need to change. And I think, orofacial cleft require interdisciplinary approach. But as orthodontists, as dental surgeons, we need to keep the patient's best interest in mind and treat them without exhausting their cooperation. Thank you very much for this opportunity, and thank you very much for allowing me to share the stage with you people. Thank you.
Thank you, sir. That was indeed, it was informative and it gave an insight into what is the role of a dentist in making, pre-operative changes which will help a primary surgeon. Thank you so much, sir. The chairpersons have to give any comments?
Lalita ma'am, Rachna.
Yeah, it was indeed a wonderful lecture by sir. I think
Hello?
Swami madam is also here.
Yeah, madam is trying to. Swami ma'am, please unmute yourself.
Ma'am, you need to unmute yourself.
Yes. Thank you, sir. Thank you very much. Thank you, Monica, madam. And this lecture is very informative. The topic is very difficult, but nicely elaborated. Again, thank you very much.
Can I ask one question to Dr. Puneet, sir?
Yes, ma'am.
Yes,
Sure.
ma'am.
Actually, very wonderful, lovely, very impressive photos that you've shown us. The changes after the surgery or this aesthetic surgeries rather. So, what stage normally these children they come to you? Are they referred very early, or they come of their own, or what happens exactly?
They are referred at birth, ma'am. We do pre-surgical infant orthopedics with surgical alveolar molding. And in the first 4 months, we make the defect very small so that the surgeon can do a good job. And then we tell them about when they should approach us. They should show us every 6 months to just look at caries. And then when the child is 7 years old, we do an X-ray to see whether it's the right time to prepare the patient for the bone graft. Once we've prepared, we refer to the surgeon to do the bone graft. And, just like normal kids at the age of 12, we do orthodontics for them. And these 30% who have this deficiency where the maxilla doesn't grow so well, we prepare them for orthognathic surgery. For girls, the age is usually 17, and for boys, it's 18. After the pubertal is over of the craniofacial complex.
Okay. Yeah, great. Thank you.
So that is lesson for all the obstetricians also, that even if baby has not been screened or seen at previously, at least after birth when we discharge, they should be given the advice that they should approach the team as early as possible. Many times they have this misconception that wait for the baby to be 3 months old or 6 months old. So I think what Batra sir says is that at birth only baby should be seen. Is that right, sir?
Is birth, ma'am. And also, I'll tell you what, in all the best centers in the world, the records are kept by the from 20 years. So, I traveled to many centers in the globe, and all the records from birth to 20 years are kept because orthodontists are trained to keep records. We are, trained for photography. We are trained for everything. So, once we become kind of the linkage between all the other specialists, the patient's confidence and everything changes. They know where to go next, because at 2 to 5, we are looking at speech therapy. So, we can, because they're showing us every 6 months, so they are not losing out on the referral bit.
Right. Yes, sir. Thank you, sir.
Mangala ma'am and Puneet sir, thank you for enlightening us in the entire postnatal journey of the child with the cleft lip and cleft palate. Definitely, most of us would have had at least a few important take-home messages regarding the care that we should, as an obstetrician, follow up with our patients. Thank you, ma'am, for highlighting the importance of counseling, both antenatally as well as postnatally, and giving them the confidence for breastfeeding. Puneet sir, your surgeries and the progress were an excellent depiction of the work done under the Smile Train Project stop. Thank you, everybody, for joining us today for an important webinar. Supriya ma'am, thank you for being the constant sort of
Monica, there
support.
are a few questions. Can I just interrupt, Monica? There are a
Yes,
few
yes,
questions
yes.
for
Thank
Mangala
you.
ma'am. Can we have that?
Harsha, is the time permissible?
Yes, ma'am. We can go ahead with the
Okay.
questions. Yeah.
Yeah, we have.
Okay.
I have a few questions for Mangala ma'am from the audience. Um, what advice would you give to the new parents who might feel overwhelmed by the challenges of feeding a baby with cleft lip and cleft palate? Mangala ma'am.
Yeah, I mean, as I mentioned very clearly, in my presentation, they do get overwhelmed.
Yes.
Seeing the appearance of the baby, which they never expected, and lot of difficulties in breastfeeding. So that is why the proper counseling, listening to them, giving time to them, and we have to do the proper counseling, not only counseling, the proper guidance and the practical help. How the baby should be at the breast, and it is just one session is not enough. We have to have many sessions, and
Yeah.
plus we have to supervise. We have to see the adequacy of the milk supply as well, and whether the
Mm.
baby is gaining adequate weight. So gaining adequate weight, how do we know? So there are three parameters: the urine, the stool pattern, and the baby's weight gain. So after
Mm.
first week, baby should pass urine at least 6 to 7 times in 24 hours. Baby
Mm.
will pass 3 to 4 times, the stools, the yellow CD stools every day, first 1 month. And the weight gain, baby loses some weight in the first week of the life. But then, and it should not be more than 7 to 8%. It should not be more than 10%. If there is a more than 10 to 12% weight loss, then this baby can likely to get dehydrated, likely to get jaundiced, or likely to get some even neurological problems. So that monitoring is very important. And after that, the baby will gain roughly 25 grams per day. So minimum of 600 grams per month. So we have to monitor. So this supervision is extremely important. So the counseling with the practical support, that is very important.
Thank you, madam. And there's another question. Are there any nutritional considerations that parents should keep in mind when feeding these babies with cleft lip and cleft palate? Any nutritional
I don't think so, because
nutritional
the breast milk
considerations?
is the complete food, and every milk is made specifically
Yes.
for that baby. So if the baby gets
Mm.
exclusively breast milk, either direct breast feeding or getting express breast milk, I think first 6 months of life, that baby's nutrition is met. After 6 months, only breast milk is not enough. So the baby
Mm.
needs the complementary feeding. So that complementary feeding should be how that it should be homemade, it should be hygienically prepared, and there are 10 food groups. So out of which the baby should get 7 food groups. And that contains all the vegetables, the fruits, the cereals, the proteins, the dairy products, the non-veg, the leafy vegetables, vitamin A containing vegetables, the vitamin D, the sunlight, or the supplementation. So all
Mm.
those things baby needs to get. With the breast milk, the baby has a good immunity, so the baby is able to sustain the infections, the ear infections particularly, those babies tends to get. And even the post-operative, their recovery is smooth once they get the breast milk.
Okay, okay. Thank you so much, madam, for answering those questions. I have two questions for Dr. Puneet, sir. Is he around? Dr. Puneet, sir?
Tell me.
There's a question. Can early orthodontic intervention reduce the need for more invasive procedures later in life for patients with orofacial defects?
Yes, see, when we make the cleft defect smaller with pre-surgical infant orthopedic, the tension of the scar is much less when we do the lip repair. Second thing
Okay.
is that once, if we've done the bone graft on time, and the patient requires an orthognathic surgery at an older age, doing an osteotomy for a two jaw split in two parts or a jaw split in three parts is much more difficult than a single jaw. So the right procedure at the right time will reduce a number of surgical procedures and also bring about good outcomes.
Okay. Yes, sir. So the other question is, how can orthodontic treatment improve the overall quality of life for patients with orofacial defects, especially in relation to eating, speaking, and social interaction?
Ma'am, all the three, eating, when your teeth are biting well, your eating is going to improve. Your speaking is, again, if you are missing teeth, there is going to be the tongue which is going to fill up the gap between the teeth. So all the words which are spoken with the tongue movement are going to be not pronounced properly. And regarding quality of life, you can see when I showed you cases that the patients, eyes glitter up, their way to face the world. See, all of us, the face is the first, place where we interact with anyone. So already they are very conscious about the cleft region, and when they have a good smile, na, it goes away. So I think if you look at the literature on the quality of life, orthodontically treated and patients who have got a good smile, their confidence levels are totally different.
Okay. Yes, sir. I think that was it. We had those questions from the audience, and those are well answered. Thank you so much, sir. Thank you so much, Puneet, sir. Thank you so much, Mangala, madam. And it was indeed a very insightful webinar. All of us have got a few take-home points. I would like to thank the MOGs, Dr. Monica, Dr. Supriya Arwari, the speakers, Dr. Mangalavani, madam, Dr. Puneet Batra, sir, and all the chairpersons for today for attending this webinar and giving in their inputs. Thank you so much.
Thank you, Pratibha, for being the master of ceremony, and thank you, Harsha, for all the technical help. Thank you, Dr. Sharvi, for joining us today from the Smile Train project.
Thank you, Dr. Monica, ma'am, and
Thank
speaker.
you.
Thank you,
Yes.
everyone.
Thank you so
Dr.
much.
Supriya.
Bye bye.
Good night. Bye. Good night.